We'll start, Sir Shankar.
Hmm.
A very good evening to one and all. I heartily welcome all the members of EPI, ICP, Karnataka, and other members of various organizations who have joined virtually from all over the country to attend this program update on dengue. On this occasion, I welcome Dr. P.S. Shankar, Professor Emeritus, RGHS and KVN University, Gulbarga, Dr. Muruganathan, past Governor, ACP India Chapter, the past Dean ICP, and the past President API, currently the Director of PRF, who will be joining shortly. On this, I also welcome our own committee members, Patron API, Dr. Maya, Dr. Murali Mohan, Chairman API Karnataka, Dr. Vishwanath, Secretary, Dr. Ravi Kirti, and Dr. Srinivas Murthy. I welcome our today's chief guest, Professor Dr. R.V. Asokan, President National IMA Headquarters, Delhi, who hails from Kollam district, Kerala, a great academician. He was instrumental in creating image project in Kerala IMA. He facilitated rupees 100 crore global fund to fight AIDS, TB, malaria. He has served as a member of Strategy and Technical Advisory Group, WHO Geneva. He was chairman of Action Committee, which shaped the struggle against NMC, a great leader, academician, researcher, and a scholar with many publications, received many awards. I also welcome our today's speaker, Dr. Suresh Kumar, a close associate of mine, a senior infectious disease specialist from Apollo Chennai, a great academician with many publications, both national and international. I welcome our today's moderator, Dr. Sanjay Pujari, a dynamic personality in the field of infectious disease, the director of infectious disease from Pune, a great researcher, academician, received many awards dedicated to science. I also invite our panelist, Dr. Ankit Mittal, the ID specialist from AIG Hospital, Hyderabad, one of the prestigious institute recognized globally, headed by Dr. D. Nageshwar Reddy, who has many publications in his infections credit. I also invite our other panelist, Dr. Swarna Deepak, consultant in critical care, Apollo Hospital, Hyderabad, handling the department with Dr. Subbareddy, a great academician and a dedicated person to critical care. Let us not waste time by reading their CV profile, which runs in pages. Let us learn and hear from them. As I can see, many have joined virtually to make this a national event, which COVID-19 pandemic has taught a new normal life to learn. Lastly, I welcome one and all. Now we have a formal virtual inauguration.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तु ते शुभं कुरुत्वं कल्याणम्.
We are also virtually honoring all our faculty members. Now I request Dr. P.S. Shankar sir for your introductory remarks. Kindly unmute it.
Dr. Ashokan, Dr. Muruganathan, Dr. Murali Mohan, Dr. Sudarshan, colleagues and friends and the faculty members. We have assembled for an update on dengue. Mosquito-borne viral illnesses such as dengue is waging a war throughout the country. Many cases have been reported from Bangalore and other parts of Karnataka recently, and dengue is the most common arboviral infection in the world and It is endemic in most tropical and subtropical countries. Dengue is a Spanish word referring to the stiff gait and the fear of motion of the patient. The term appears to have originated from a Swahili phrase, "Ki denga pipo," means a sudden cramp like seizure from an evil spirit or plague. Dengue virus, belonging to the family of the Flaviviridae, is a single-stranded RNA virus. There is considerable genetic diversity in the dengue virus family with 4 serologically distinct serotypes. Dengue fever can be caused by any one of these 4 serotypes of the dengue virus. The infection with one serotype confirms lifelong homotropic immunity only to that serotype, and recovery from an infection with one serotype does not confer protection against the other 3 serotypes and are still susceptible to the infection with the other 3 serotypes. The main reservoir for the dengue virus is the humans. The virus is transmitted through the bites of the infected female mosquito belonging to the genus Aedes aegypti, and Aedes albopictus. The mosquito is found in the urban surroundings. The mosquito is identified by its peculiar white spotted body and the legs and is given the name tiger mosquito. It is highly domestic and breeds near the human habitat in standing water collected in containers. Peculiarly, the mosquito is a daytime feeder and it bites many people to get its blood meal. Persons who stay indoors during the daytime are vulnerable to mosquito bites. Overcrowding, poor living conditions, lack of vector control facilitate the spread of the infection. Dengue is endemic in both urban and semi-urban areas of India. The burden of dengue has increased at least tenfold over the last 5 years. The manifestations vary from mild fever to severe fatal hemorrhage. Dengue hemorrhagic fever, dengue shock syndrome develop due to an increased capillary permeability and vasodilatation 3 to 7 days after the commencement of illness. There is a storm of cytokine secretion, including tumor necrosis factor alpha, which disturbs the delicately balanced cytokine cascade. Cytokines play a major role in the pathogenesis of dengue hemorrhagic fever. The disease exhibits a variable severity. The clinical picture of dengue fever is highly variable and it depends on the age, immune status of the host, and the virus strain. The World Health Organization has classified the disease into dengue fever and severe dengue, including dengue shock syndrome. The patient experiences severe myalgia, backache, and arthralgia, hence the condition is often referred to as breakbone fever. Hematological examination reveals thrombocytopenia, leukopenia, and lymphopenia, raised levels of the hepatic aminotransferase and lactate dehydrogenase and hyponatremia. Dengue hemorrhagic fever is characterized by systemic vascular leakage and coagulopathy. There is a capillary leakage 4 to 7 days after the onset of the disease and occurs as a capillary leak syndrome. There is a marked fall in the platelet count and raised hematocrit. There is a close association between the drop in the platelet count and the rapid increase in the hematocrit. Dengue shock syndrome is the most serious manifestation of dengue hemorrhagic fever. There is an increase in the IgM antibodies 4 to 5 days following the onset of fever due to the primary infection from the dengue. IgG antibody appears 7 to 10 days after the infection. There is no specific therapy for dengue, and the treatment is essentially symptomatic and supportive. Restoration of circulating plasma volume is a cornerstone of the therapy for the patients with the dengue shock syndrome. Vector control is essential in prevention of dengue. The environment must be free of the potential breeding sources. Application of the insecticide repellents and the protective clothing are advocated. And we have assembled here for an update on dengue, in which many leading experts are taking part, and we are eager to hear them. And I wish the program a success. Thank you.
Thank you, sir. Thank you for your kind words and your introductory remarks on covering the subject. Now I request Dr. Muruganathan to deliver his inaugural address, guest of honor. He is held up in a meeting, sir. Now I request our chief guest of today's function, Dr. Ashokan sir, to deliver your inaugural address. Over to you, sir.
Thank you, Dr. Sangram, brother. It's such a pleasure that you followed me very closely to get this date and get involved in your very good program. I am so happy to be associated with the API, though my time is taken by IMA. It's a pleasure to be associated with the API because I also happen to be an API member, and we got really associated in the national API meeting. And I also acknowledge Dr. Murali Mohan, Dr. Vishwanath, and Doen, and your patron, Dr. Maya, Dr. P.S. Shankar, and Dr. Muruganathan, Dr. Suresh Kumar, and the panelists. It's such a pleasure to be associated. Many times with the government, when we take up issues like infectious diseases, tuberculosis, dengue, with the government, the clinician's point of view is lost. Many times, the clinician's point of view is not given importance. And there is a large gap in the understanding because of that factor. And I have insisted repeatedly that this particular thing has to be rectified. I'm so happy to inaugurate this dengue update by our experienced panelists. I congratulate the API Karnataka and the ICP for conducting this program. Thank you so much. I declare it as inaugurated.
Thank you, sir. Thank you for sparing your valuable time and inaugurating the function. Now we move on to the scientific session. I request Dr. Sanjay Pujari to take over for further proceedings since all the faculties have been introduced. Dr. Sanjay?
Yeah, thank you, Dr. Biradar, for having me. It's nice to see you again virtually. Uh, uh, I think dengue is such an important infectious disease, tropical infection particularly, but of course now it's seen in temperate climates as well. And currently the monsoon season is where you see the peak of dengue cases. And at the clinic level, at the outpatient settings, at the GP level, right up to the critical care settings, there is a spectrum of people who are involved in trying to diagnose and manage dengue. So without further ado, I would like to invite Dr. Suresh to give us a presentation on dengue, and then we will have a brief discussion. I would also request the audience, if they have any questions, to just put it in the chat box so that I can scan them and ask it to a panelist. So right over to Dr. Suresh.
One second, sir. Right now it's functioning then.
Yeah, please go ahead. You're not able to share the screen.
Yes, sir. One second. I just tried with that. Some issue is.
I think you joined from two devices. Kindly close one and
Okay, I'll do it then.
yeah.
My screen is visible.
No, you are join. Yeah, now it is visible.
Okay. Sir, slides are visible.
Yeah, now it's okay. Yeah, you can go
Am I
ahead.
audible?
Yeah, audible.
Okay. So I sincerely thank the AP Karnataka chapter for giving this wonderful opportunity, as well as the kind words of introduction by the chairperson. So everybody knows dengue. I'm going to provide an overview of dengue, what is happening currently now. So disclosures nowadays, most of the tools are created by AI, and AI is doing the presentations also. But unfortunately, today AI is not helped me to creating the tool. This is the tool. This is the disclosures I created these presentations. Nowadays, we need to disclose whether AI is created or human is created. So this is created by the human only. Straight away, I begin with the case here. 40-year-old male, diabetic, he's from Chennai, 4 days of fever and chills. He got body pain and back pain, headache, vomiting. It was apparently normal till 3 p.m. 4 days back. No sick contact. On examinations, febrile, diffuse erythema was noticed. Vitals were stable. Rest of system examination was normal. So I'll ask the participants, please go ahead and vote so that we can have discussions towards the end. What will you do now? When a patient of 4 days fever with chills and diffuse rash, vitally stable, rest of system normal. So whether you want to give symptomatic treatment, plus I do some basic investigations in the form of blood count and MPQBC, along with the dengue serology, NS1 plus IgM, plus antibiotics. No, my approach is different. So please go ahead and vote so that we can discuss towards the end of our presentations. I'll give a minute for people to vote right now. So this case is going to come in a couple of minutes later also. So please keep watching this case so that we can discuss towards the end. So why dengue overview today? We know dengue is common, but nowadays dengue is spreading to across the continent, I can call. People say US it's not common. Usually any acute fever with rash, I can put my money on dengue in India. But if it is US, I can't put this dengue is first diagnosis. But now is dengue is reaching not only Europe, in France, for example, Olympics is going to start. That's a huge concern of dengue. And second thing, right now, US is also reached. That is why we are discussing today. No, the only government, only the state I know is keep reporting dengue cases is Karnataka government. And they daily monitoring the trend of dengue. Other states are not reporting like this one. So if we see what is the status of dengue in Karnataka, they are mentioning. So that's why we are discussing with the APA Karnataka chapter today. That is also not the reasons. And this is a reason. Dengue is both established, it's emerged as well as re-emerging infections. It is a big headache for everybody. The numbers keep rising every year, as well as every quarter or every season it rises also. My chairperson kindly told this is a seasonal incidence now, and WHO is telling that 2.5 billion people are at risk. 300 million people are annual infections is happening right now, and hospitalization is only tip of the iceberg. Most of the infections are asymptomatic or mild viral fever. People won't recognize this as dengue. And circulations of all 4 serotypes, but compared to dengue serotype 1 and 2, 3 and 4 is less commonly circulating. That is why we are discussing. Not only in Karnataka, dengue is common across India. This is little older data. I got the data. Almost 3.6 billion people across the world at risk of dengue. 12.9 million dengue infections happening in India till 2017. India contributes almost 30% of dengue cases to the global world. Overall, the zero prevalence is 48.7 in India, highest in southern part of India, as well as western part and northern part of India compared to the eastern part of India. Maybe the data, I need to check whether the data is emerged from the eastern part of India compared to this part. For example, western part and southern part, the data is good. So there are a lot of data available for the clinical studies to show what is the prevalence of dengue. So the reasons for dengue discussions overview today is these are the reasons. One, dengue is an emerging and re-emerging infections. According to the seasons and off late, according to the climate changes also it's happening. And third thing, India is a leader, almost contributing 30% of a burden to dengue. And nowadays also, as rightly pointed out by Karnataka data, number of cases has been reported keep increasing in the last couple of weeks. So because of the climate change, a lot of infectious diseases has changed the pattern, and all mosquito-borne diseases after the climate change is on uptrend. It's an uptrend for the last couple of years, I can put it right now, and we need to monitor closely for the next decade. What is the impact of this climate changes on the impact of vector-borne diseases in huge. So that is why we are discussing today. So the virus already chairperson clearly told this is a flavivirus, single stranded RNA. There are 4 serotypes. Almost all the serotypes are circulating in India. But as I told earlier, dengue 1 and 2 is more commonly circulating compared to 3 and 4. So this is a dengue virus. And what is the pathophysiology? This is also is eluded. Once the mosquito bites you, the virus enters your blood, which causes viremia. After the viremia, the 2 things can happen. One, direct effects of the virus on your system, and second thing, because of the immune system, either T cells or B cells, causes a problem. And finally, the cytokine release is happening once the immune system is get activated and causes your endothelial cell damage, capillary leakage, as well as coagulation profile abnormality. Platelet dysfunctions as well as platelet number death is one of the small component of the dengue, but most of the treating clinicians, they think more weightage to the platelet component compared to the overall pathophysiology. That is a basic issue. The overall pathophysiology is not only the platelet destructions or platelet thrombocytopenia. The issue is more of capillary leak, more of coagulation profile abnormalities, and endothelial dysfunctions rather than platelet dysfunctions alone. So we need to keep in mind the overall pathophysiology before start treating the patients. So infectious disease is always equal to syndrome. We are similar to sexually transmitted disease physicians or research neurologists. When we come across any patients, we want to put a syndrome so that we can make a diagnosis. So what syndrome? As a clinician, you need to think about it. This is an acute fever syndrome without any major localizations. I can put it right now. Fever, headache, body pain, some skin rashes, nausea, vomiting, or abdominal discomfort. So this is a major presentations of most of the viral fever. And dengue also fits into the acute undifferentiated febrile illness syndrome only. So anybody with acute onset of fever, body pain, skin rashes, along with some abdominal discomfort, nausea, vomiting, you need to think about dengue in the differential diagnosis. Particularly countries like India is an endemic always, and always seasons is going around. And as far as signs is concerned, the typical sinus conjunctival suffusions can happen and diffuse erythema. Initial stages, diffuse erythema. Later part of the stages, the normal skin start happening between already diffuse erythematous skin. So area of islands we can call. That is one of the important sign when patient dengue is getting over and start recovery is happening. And most important thing, we can suspect dengue, but if you want to prove dengue, because almost all the viral fevers, for example, dengue, chikungunya, Zika, almost all the presentations, fever, body pain, headache, and more of joint pain in chikungunya, more of back pain here in dengue. So minor differences only. So we need laboratory to confirm our diagnosis, whether it's dengue or not. So the ID syndrome here is acute undifferentiated fever with back pain, body pain, along with rash, nausea, vomiting. Think of dengue. The other key is most of the time the fever is don't last for more than 7 days. Usually most of the viral fever, the dictum is it should last for 3 to 5 days, at max 7 days. So when the fever is lasting more than 7 days, always doubt whether it's really dengue or something dengue along with some complications of the dengue, we need to think about it. And this is a WHO standard definitions, how to suspect dengue in a clinical practice. So nowadays, previously the dengue is divided into dengue hemorrhagic fever, dengue shock syndrome. The classification has been changed from 2009 onwards. So we need to have 3 things, only 2 things, dengue or dengue with warning signs and dengue, severe dengue. So these are the 3 cases we need to know. Dengue with warning signs, and severe dengue, we need to make a diagnosis. So when to suspect dengue, probable dengue, when a patient has got living in endemic country like India and presents with fever, sudden onset of fever, along with couple of characteristics like nausea, vomiting, or rash, and aches and pains. So these are all the characteristics of the features of the dengue to suspect when dengue is happening. And as far as once you make a diagnosis of dengue in a differential diagnosis, you need to think about warning signs, because the warning signs only make you think where to manage the patients, whether in OP or IP or ICU. So when a patient has got warning signs, means these are all the classic warning signs: abdominal pain, patient has got persistent vomiting, or patient has got bleed, particularly the mucosal bleed, or lethargy or weakness, and patient has got enlargement of the liver, has this abnormalities of the liver functions. So these things we need to think about it. And most important thing, the concentrated hematocrit, that's most important thing. So when you make a diagnosis of dengue, when a patient presents with acute fever, along with two other following features, either nausea, vomiting, rash, aches and pains, or tourniquet test positive, think about dengue. Once you think dengue as a differential diagnosis, think whether warning signs is present or not. And once the warning signs are done, make a diagnosis of dengue. Always think about severe dengue. When to consider severe dengue, when a patient has got bleeding, particularly the mucosal bleeding, not your gum bleeding. This is mucosal bleeding, GI bleed or GU bleed. Particularly women has got menstrual bleed is quite common, but sometimes the intensity as well as the degree of the clots is more. We need to think about severity. And when the platelet count is also low, elevated ALT parameters and AST parameters, CNS involvement, and heart and other things like myocarditis, we need to think about severe dengue. So these are all the differential diagnoses we need to offer. So coming back to this, my case, what do you think? I have given when to suspect dengue as per WHO criteria. So please go ahead and vote so that we can have a discussion towards the end. 40 LY, same case only. What do you think? The patient has got dengue. How many say yes, this is dengue? No, this is not dengue. Something else is going on. Or maybe this is one of the differential diagnoses you can consider. I need the NS1 antigen test or dengue IgM test. Wait till panel discussions. After the panel answer the things, I can answer the answer. So people are waiting for this one. I'm not sure. So go ahead and vote so that we can have discussions towards end of our presentations. So I validated this criteria and presented couple of years, not couple of years back, almost a decade now, whether this criteria holds good or not. So how many dengue patients I made a diagnosis based upon WHO's acute onset of fever, rash, nausea, vomiting, skin rashes, I need to make a diagnosis. We validated the test and presented a paper in DICMED. It showed the sensitivity and specificity of this character, particularly the WHO definition is not great. It misses a lot of cases. It has got only able to pick almost 45% to 50% of the cases, not more than 45% to 50% of the cases. So our suspicion should be very strong. So don't think I applied WHO criteria. So I made a diagnosis of dengue. Usually the WHO criteria lacks a lot of sensitivity and specificity issues is going around. So in clinical diagnosis, anybody has got diffuse erythema or severe conjunctival suffusions or blanching sign. This is called dermographism we call. When a person's diffuse erythema not noticed in a black skin, just keep your hand and just remove it. You can notice the erythema. So this is one of the important parameter. We can able to make a dengue diagnosis clinically. Sudden onset and during the time of recovery, normal skin can happen between erythema. So dengue usually based upon the clinical picture, sudden onset. Along with this thing, we can make a suspicions of dengue. And what is the assessment we need to do? We need to assess the color of the skin, not only color of the capillaries. We need to assess the color of the skin, and we need to check the capillary refill. Whether the severity, we can do assessments along with temperatures and pulse volume and pulse rate. To assess the severity, these things can have in mind. So this is called 5-in-1 maneuver or magic touch maneuver, you can call it. Right now, we know country like India and country seasons like influenza, dengue, chikungunya are overlapping. We need to know what is the best way we can differentiate. Usually the back pain, the severity of the back pain and retroorbital pain, that is more common. Cough is also present, but not like your influenza, like sore throat, nose block, running nose. These things is quite common with respiratory illnesses like influenza-like illnesses. It is more of systemic nature. For example, body pain, joint pain, retroorbital pain, skin rashes, along with mild amount of cough when possible. So this is a typical presentations of dengue. So this paper, the Lancet Global Health paper last year clearly showed how to differentiate commonly circulating illnesses in tropics compared to dengue. This picture can help you out. So differentiating dengue from other families is always a dilemma. Country like India, always a dilemma, whether it's a dengue, whether it's malaria, whether it's typhoid, whether it's chikungunya. I'll provide a little bit more data towards my end of presentations, how we are differentiating whether dengue versus typhoid or dengue versus other illnesses. We'll just provide some idea to you people there. So does these patients have dengue? What, even though WHO criteria can help for primary healthcare physician to suspect dengue or suspect viral fever. What is a typical dengue fever for an ID physicians? Short onset of fever. I told this case is called sharp onset, 3 p.m., 4 days back. Most of the time, viral fevers, the patient can tell the time of the fever. Doctor, I was normal up to 2 p.m. or 3 p.m. The fever started, exact timing. In case of typhoid, it's very difficult to pinpoint the timing. And second thing, diffuse body pain, particularly back pain, retroorbital pain. and diffuse rash and blanching rash, always put your money with along with conjunctival suffusions. You can think about dengue in your clinical practice. So what are all the history? Clearly, this history plays a big role, but physical examination has got worth. We need to examine the persons, try to look for other signs of other etiology. For example, HCAF or scrub typhus. Similarly, we need to look for leptospirosis by eliciting history, whether travel in any rainwater exposures or wading in the rainwater, we need to know. Typhoid means I need to take the history of eating outside food. So don't think by just getting the fever, body pain, make a diagnosis of dengue. We need to get the proper history to rule out other common tropical infections happening in country like India. We need to do it. People are always thinking malaria is a differential diagnosis and they want to give malaria prophylaxis, chloroquine for almost all fever, chills and body pain. They want to give unless otherwise proved this is malaria for most of the clinicians. But number of malaria cases has come down. In fact, the dengue has eclipsed the malaria for me. Now, number of cases of malaria, what I'm seeing is hardly 1 per month or 2 per month compared to dengue cases, what I'm seeing in daily basis. The malaria incidence has gone down in Chennai, at least for me. The incidence of malaria is almost nil to me compared to what the cases of dengue I'm seeing right now. Dengue is overtaken. Definitely malaria cases has come down. It fully eclipsed malaria to me there. So dengue has taken over compared to malaria. So instead of giving a chloroquine prophylaxis, we need to think about other etiologies to find out what is the cause of acute undifferentiated febrile illness in country like India. That's more important for you. So coming back to this case, I show more important features. For example, I'm giving some basic features. Hemoglobin is 16.4. WBC count was a bit low, and the patient has got platelet count of 1.52 on the lower side. ALT was slightly elevated. AST is also elevated more compared to ALT. Alkaline phosphatase is on normal side. GGTP is also normal. Malarial parasite by QBC method negative. Vidal is positive in 1 in 40 dilutions. Dengue NS1 and IgM was negative. IgM was positive for leptospirosis. Now this is interesting. Just go through the reports and try to vote what is your diagnosis. Even though according to the WHO and according to the ID physician's criteria, acute onset of fever started 4 days back, sharp onset, body pain is present, back pain is present, diffuse rash is present as per WHO criteria. 2 criteria are fitting, but unfortunately the dengue NS1 and IgM is negative, but lepto is positive, Vidal is 1 in 40, and other parameters are essentially normal except low WBC. How many think this is a diagnosis of dengue? Other diagnosis is offered. I just give you a half a minute so that you can go ahead and vote so that we can discuss towards the end of our presentations. Okay, sure. So when you got the diagnosis, clinical diagnosis, as I told you earlier, dengue, chikungunya, and other viruses, Zika, always overlap. So we need to make a diagnosis to be confirmed by laboratory. We can suspect dengue clinically, but we need to prove dengue in the laboratory. For that, we need to know the natural history of dengue. Once a mosquito bites, the person went to an incubation period of 3 to 5 days or 2 to 4 days, we can put it. Afterwards, the patient start manifesting fever. That is a period of viremia. Viremia, it lasts for 3 to 5 days. After the viremia subsides, the patient enter in a critical phase where that point of time, the shock can happen. Then finally, the person starts recovering. This is a natural history for most of the dengue patients. Only few patients can land in dengue shock syndrome, or the patients go for severe hypotension or bleeding. That can happen after 5th day of illness. So when a mosquito bites, first 3 to 4 days of incubation, then febrile phase of 3 to 5 days, where suffering will be more, dehydration is more common. Then once fever is over, the patient may develop some abdominal discomfort, abdominal distensions, pain, along with hypotension, shock can happen, or bleeding manifestations can happen, or other systemic involvement can happen. So remember this phase so that we can make a diagnosis. And dengue test, there are 2 types of tests. One is called direct test, other is called indirect test. Direct test, always we want to check the viremia in the form of PCRs. Right now, dengue PCR is available in most of the major cities, not in the second level hospitals, but major city corporate hospitals, PCR is available. And second thing, equivalent to PCR is NS1 antigen. I'll come back and explain what is the differences between NS1 antigen and PCR. And indirect test is always serological test. But the catch is serological test need a little bit of time. We need to do the serological test after 5th day or after 7th day of illness, because body should recognize a pathogen and it start producing antibody. It will take time, particularly dengue, IgM and IgG. I'll explain in the next slide what will happen. So these are all the confirmatory tests and these are all the These are all the tests for using commonly in our day-to-day practice. For example, there are two types of dengue. You are getting first time dengue, that's called primary dengue. You are getting second time dengue, that's called secondary dengue. In primary dengue, as I told earlier, NS1 appear on day 1 of the illness. It appear on day 1 of the illness and it can last for day 2 or day 3 maximum. But most of the cases on day 2, it starts disappearing. And similarly, IgM start forming from day 5 to day 7, and it can last for up to 2 weeks, or sometimes it can drag up to 3 months also. Then IgG start forming from 10 to 14 days later. This is for primary dengue. But in secondary dengue, the intensity of IgG is more. So it can mask NS1, it can mask IgM. So the person can straight away manifesting IgG on day 2, day 3. So depending upon whether primary dengue or secondary dengue, we can able to know based upon the clinical presentations. But where is the role? Dengue PCR can help out. Even though the NS1 is masked by your IgG in secondary dengue, but PCR can still pick it up because the viral load is still high on day 1 to day 5. So PCR can pick up the dengue. So if you clinically suspect the patient has got dengue, like the case what I shown earlier, the patient is clinically dengue, but on day 4 you are doing the test. That's why NS1 formed and disappeared. IgM still not formed. So the patient has got no man land. That is why the dengue PCR can help you out whether the patient is dengue or not, because it can remain positive for minimum 5 days, up to 7 days. The dengue PCR can remain positive. So if clinical suspicion is very high, we need to do, when the clinical suspicion is very high, we need to do the dengue PCR test. It's more important for us to make a differential diagnosis. So dengue NS1 positive, acute dengue infections. If it is negative, it does not rule it out. As I told earlier, what is the time period that is more important? Viral RNA PCR, again, it is sensitive, but we know in COVID PCR itself, sometimes classic COVID, but patient still misses out COVID PCR. All PCR has also got limitations. Sometimes the dead bacilli or dead viruses also can pick it up with the PCR. History of more than 5 days illness, ideally think about dengue IgM serology, but ideally the pack seroconversions. Initial test is negative, 1 week later or 5 days later the test is positive. It's called seroconversions. Negative to positive, that is more valid compared to one positivity. As I told earlier, dengue IgM can remain positive for 3 months, so it's a bit difficult for us to make a diagnosis of it because of the old infection still remaining positive, and IgM serology always take pinch of salt. It can cross-react with other viral infections, particularly the flaviviruses, whatever circulating, it can cross-react. During COVID time, we encountered a lot of dengue IgM positivities happen because of the COVID. Even though COVID does not belong to the flaviviruses family, but still a lot of cross-reactivity can happen. Dengue IgG, yes, in secondary dengue, it is very valid test, but other situation, it has got very limited role for me. So what test and what time period? Between day 0 to day 3, not even day 5, I can put it day 0 to day 3. On the day when the patient develops fever, you can do NS1 antigen. Between day 0 to day 7, dengue PCR is good. 5th day onwards, dengue IgM is good. If you think the patient has got secondary dengue, you can rely on dengue IgG little earlier. Otherwise, dengue IgG from 10 to 14 days. But what is more important, read the WBC count or read the complete blood count. And the hemoglobin is concentrated and the WBC count is normal or below normal. Differential count see more of lymphocytes and platelet count is normal or below normal. And if you read SGOT, SGPT and LFT test, OT is elevated more compared to PT, and alkaline phosphatase is normal. Mild elevations in jaundice can happen. So the CBC LFT, if you do in a good lab, you can able to suspect dengue based upon CBC LFT. Elevated hemoglobin, low WBC count, low platelet, elevated SGOT, mild elevations in SGPT, other parameters of LFT normal. You can think of dengue, provided the history is short one. So this is what we need to suspect and we need to order the test accordingly. So we need to know what is the role of RT-PCR, what is the role of NS1 antigen and serological test before test for dengue. For example, depends upon your resources. If you're practicing in a primary health center, you don't have access to the PCR, even serological tests or NS1. Sometimes people are using card test. Card test always has got limitations, but at least CBC LFT is available for most of the hospitals or most of the primary care centers. CBC is fine to suspect dengue. That's why it's shown how to suspect dengue based upon the CBC alone. If you are practicing in a secondary or corporate hospitals like tertiary, both PCR, NS1, everything is available to you. So depending upon situations and depending upon the affordability, we need to ask for the test. So tropical infections, how to differentiate? This is a question we are asking constantly. based upon the CBC and LFT and based upon the proper history. For example, malaria numbers is going down, even though people say classic intermittent fever, chills and rigor, and splenomegaly, put your money on malaria. But nowadays, intermittent fever, chills and rigors is not happening with malaria, and very difficult to say. Malaria is very rare to me, unless travel-related malaria. But based upon the CBC, and the hemoglobin is low, dengue is elevated. In malaria, hemoglobin may be normal or low because of hemolysis. WBC count again may be normal or low like dengue. But if you see the platelet count can be low in malaria also, but not too low like dengue. In dengue, we can see 3,000, 4,000, 10,000, 25,000. But malaria can average in time and average varies between 50,000 to 70,000. On the other hand, if you see the SGOT bilirubin, more of indirect bilirubin in malaria. If you see the typhoid, if you see WBC count may be normal, hemoglobin may be normal. Sometimes the WBC may be on the lower side. But what is glitching typhoid? Look at the eosinophil count. Differential count, neutrophil normal, eosinopenia along with normal ESR. If you do SGOT-PT, SGPT is slightly elevated compared to SGOT. And leptospirosis and scrub typhus WBC count is always elevated. Platelet will be low, but not like dengue too low. And if you see the LFT, more of direct bilirubin and more of cholestatic picture. Dengue and typhoid, more of hepatocellular pattern. Leptospirosis and scrub, more of cholestatic with alkaline phosphatase and GGTP. This is how, in resource limited setting, we need to think about tropical infections. Coming back to this case, now what will you do? Now I'll put into treatment part. Now the platelet count has been repeated. Platelet count is 12,000. SGPT is 642. So what will you do? How many want to transfuse platelets? Start papaya extracts, start steroids, start antibiotic, or you want to refer? So please go ahead and put so that we can discuss towards the end of these presentations. Okay. So the dengue case management depends on what sort of individual, influenza, dengue, and even HIV, people want to put stage, what stage the person belongs to, whether the person is group A or group B or group C. Particularly for influenza, we say patients, young healthy persons without comorbid, we can manage without any antiviral, without any testing also. Similarly, dengue also, the person is young, no comorbid conditions, and there is no evidences of capillary leak or no evidences of hypotension or shock. We can send the person home and manage home, provided the person does not have any major comorbid conditions. On the other hand, patients has got comorbid conditions, or the patient's platelet count is less than 50,000, or other parameters of capillary leak or hypotension is persisting, the patient need to be hospitalized. But when person showing signs of severe dengue in the form of elevated LFT parameters, not able to take anything, the patient has got bleeding, then point of time we need to hospitalize in the intensive care itself or monitoring closely. That belongs to category C or group C. So this is a classic dengue case management prepared by our National Health Mission. Most of the patients, if you see dengue, it is an uncomplicated viral fever. Fever for 3 to 4 days, mild decreases in platelet, mild decreases in WBC, mild elevations in LFT, and within 2 to 3 days, person start recovering. This is a natural history for most of the people. But people going for complications is very 10%, particularly children, obese children, or persons with obesity. Person getting second time dengue, the chances of complications, the plasma leak as well as capillary leak and bleeding tendencies is more common in only certain populations. We need to think about it, and we need to find out who are the populations. So, and we need to know the phase of the illness also, what phase the person presents. First 3 to 5 days, most of the people, once they made a diagnosis of dengue, they will approach you for hospitalizations. But unfortunately, this period we can manage in the home. The person should be ideally come to the hospitals in critical phase. Once the fever subsides, that is the most important phase. At point of time, the person should come to the hospitals. Close monitoring is required. And within 2 to 3 days, the critical phase will be over and start entering the recovery phase. During recovery phase, a lot of tiredness, asthenia can happen, and sometimes mild cough can persist, and some uneasy feelings can go on. And we need to look for some of the organ-specific manifestations, neurological manifestations, as well as cardiovascular manifestations in the form of myocarditis is quite common. Sometimes the patients can go for hemophagocytic histolymphocytosis can also happen. That time again, one more episode of fever, again count can drop. This thing is quite monitoring. But we need to find out the risk factors. Secondary infections is one of the risk factors for severe dengue. Obese people, people with comorbid conditions, particularly pregnant women, we need to think about complications and we need to suspect Who are all the persons go for complications? That is very important. When to admit according to WHO, the person should have in shock or dangerously low platelet. That means 50,000 less is usually need for hospitalizations, but transfusion only less than 10,000. Those with progressive disease and warning signs, high-risk patients like children and elderly or comorbid conditions, we need to hospitalize. So we need to closely tell the patients when you're sending home what are all the parameters they're supposed to see and what are all the parameters are supposed to manage. And fluid management is one of the commonly asked questions for clinicians, how to start fluid. Because if you give fluid too much, at the time of recovery phase, the person can land in pulmonary edema. On the other hand, if you give too low fluid, the patients can go for a capillary leak, hypotension, shock can happen. So usual dictum is the person has got only warning signs without any shock or without any capillary leak. Usually we can start him on 3 to 5 ml per kg of the body weight, that's fine. Infuse over 1 to 2 hours, monitor the patients. The patient is showing signs of improvement, you can come down on a fluid. Because if you give too much of fluid, the person can land in edema. The best fluid is when the person is taking orally without any vomiting. Oral fluid replacement is better compared to anything. On the other hand, if the person showing compensated shock, instead of 3 to 5 or 5 to 7, we can go up to 10 ml per kg of the body weight. And we can closely monitor for next 2 hours. The person showing signs of improvement, come down to 5 to 7 ml, then again 3 to 5, can gradually taper and stop it. Suppose the person is not showing any improvement, whether challenges in boluses is needed or not, we need to decide. Similarly, when the hematocrit is falling, despite the patient is not showing any improvement, think of any blood losses. So we need to think about transfusions of the blood. That is more important. And the person's in decompensated, compensated shock is fine, decompensated, we need to give fluid boluses. Apart from the standard doses of 10 ml per kg, we need to give. Sometimes people are giving 15 to 20 ml for a couple of hours. Once stabilizations happen, they can come down. But here fluid boluses may require, or sometimes vasopressors requirements also needed for these situations. But closely monitor hematocrit. Based upon the hematocrit, based upon the clinical presentations, we adjust the fluid. The main aim is try to avoid overload the patients with the fluid. That's most important thing. So the dictum is first 1 to 2 hours, 5 ml per kg is more than sufficient. When a patient with warning signs, a patient has got mild capillary leak but compensated shock. And next 1 to 2 hours, 3 ml per kg. And next 1 to 2 hours, 2 ml per kg. So 5, 3, 2 is the rule. We can use it and we can taper it. But once the person start taking orally, come down on fluids. That's most important thing, keep in mind. When to discharge the patients, absence of fever, return of appetite, all the components is clinically better, good urine output, minimum 2 to 3 days recovery from the shock, no respiratory distress, count is maintaining above 50,000. That point of time, yes, you can discharge the patients. So this is the guidelines I've taken from the last year. The national guidelines is published. So if you are confused with the fluid management, please read these guidelines. It clearly shows what is the fluid requirement. Usually 5 ml per initial 1 to 2 hours, then 3 ml for next 1 to 2 hours, 2 ml per next 1 to 2 hours. That's a simple dictum. If the patient is in shock, we can increase the fluid. The person taking orally, come down on the fluids. That's a simple mantra. Now people want to know, is there any therapeutic drugs I can use it? So this is a controversial subject right now. A lot of things has been tried. A lot of things has been tried in the past, but so far there is no elusive treatment available right now. So what clinicians want to know, when the platelet count is low, they want to know whether steroids can improve. Steroids can transiently increases your platelet count, but studies, particularly the Cochrane review, clearly showed there is no benefit of steroids. Later time, it increases the complications, particularly the bleeding risk is very high. So try to avoid steroids. Don't show improvement in the platelet. I told in the pathophysiology, platelet dysfunction is only a smaller part of dengue pathophysiology. More of endovascular dysfunctions, capillary leak, coagulation subnormality. This is more important role compared to your platelet count dysfunctions. Then people want to know what is the role of this papaya extract. Huge market in Indian governing, but most of the time they use during the convalescent phase. And the person start recovering, that point of time they use, automatically they're recovering rather than because of the papaya extract. Even though they put a lot of benefits, this review clearly showed right now there is no evidence to say any mortality benefit or any improvement in the platelet or any improvement in the bleeding risk. I don't think so any role for papaya extract for dengue till today. This is taken from the Alternative Medicine Journal. They themselves analyze the thing and they're saying there's no benefit right now. Regarding the platelet transfusions, prophylactic platelet transfusions I'm talking about, that means when the patient has got above platelet count of 10,000, people want to transfuse because of the fear. There is no role. This Lancet paper clearly answered there is no role of prophylactic platelet transfusions. In fact, it increases the complications. transfusion related complications as well as the volume overload related complications can happen. Again, this is a paper. It clearly shows prophylactic platelet transfusion has got no role. Therapeutic transfusions and the platelet count is less than 10,000. Yes, we can consider, but again, the data is not great. Patients bleeding itself, for example, gum bleeding or menstrual bleeding, don't consider importance. We need to closely monitor, but that is not an indication to transfuse. We need to closely monitor other parameters. So the role of platelet transfusions, usually it is very doubtful and controversial, but according to WHO, less than 10,000, yes, we can transfuse because some evidence is lacking. But in government sectors and public sector hospitals, even people do very well with 3,000, 5,000 counts without any transfusions. So keep in mind, this is one of the Indian editorial written clearly. This is for our false comfort. This is not for the patient's comfort. This is for the physician's comfort. Platelets are transfused. In fact, we analyze our own data. The average platelet transfusions is one of the city hospitals is 35,000. Platelets are transfused around 35,000. Unnecessary transfusions and unnecessary antibiotic use is common in dengue. Then what about other drugs like chloroquine? Like COVID time, chloroquine has got no role. People tried with other things like palapravir as well as other antiviral medications and ivermectin. These are all the things whatever tried for COVID, they tried for other viral illnesses also, but there is no good data. But one drug is called the Eltramobag. That is one of the things that's showing some improvement. Instead of giving a steroids or instead of giving a platelet transfusions, this is going for trial. I'm not recommending right now, but increases the platelet count and decreases the bleeding risk. But again, the mortality benefit we do not know. But only a couple of studies only started, but no recommendations for this one. But compared to people giving steroids, compared to transfusing the platelets, so those who want to keep peace of mind, you can do some good studies, enroll the patients, and think about whether Eltramobag can use this one to improve the platelet count and keep your mind calm. You need to think about it. And regarding the dengue vaccine, the mantra after the COVID is vaccines. There are 3 vaccines right now available. One is called Dengue Vaxia, and the second one is called TAC-003 and TV-003. What is the difference? Dengue Vaxia is 3 doses, 3-dose vaccine schedule. TAC-003 is 2 doses and TV-003 is 1 doses. But what is the problem with vaccinations? We need to know the seroprevalence. It has got more protection for the person already had dengue compared to a person without dengue. The chances of having severe complication expected after dengue vaccination. That's why Philippines has stopped giving vaccinations for dengue vaccine. Second thing, how long the immunity is going to last? That's other questions. And third thing, right now, Brazil has used this TAC-003. Again, they are seeing a lot of dengue 3 and dengue 4 viruses is emerging. So we need to think about it. Right now, dengue 1 and 2 is common. And after the vaccination, 3 and 4 is also emerging. Even though all the vaccines contain 4 serotype, but the protection is not lasting longer and increases the risk of second-time dengue. So right now, the dengue vaccine is controversial area. This beautiful editorial written in February. Right now, WHO says 3 doses of dengue vaccine for people above the age of 9, and TAC-003 we can take above the age of 6 years to 16 years. Particularly children, they're recommending it because complications as well as severity is more. But right now, people say this is called the TAK-003 vaccines. TACDA is a name there, but even we can't take that in India because we need to do good trials. Whatever trials is happening in the endemic country like Philippines, Indonesia, and Singapore, but there's no good trial. Couple of trials is planned in India and phase 3 trial for the latest vaccine TV-002. They are doing it now. But right now, if there is no exposure, please don't take dengue vaccines. The chances of complication is a bit high. Try to avoid the dengue vaccines. So vaccine is not available and therapeutics has got no role. So what is the role of controlling the vaccine? Controlling the vectors, that is the most important part. Now the concept is called Wolbachia. This is a symbiotic bacteria used to reduce the lifespan of the mosquitoes as well as potential to grow the viruses in the body, thereby preventing it. A lot of success is happening in Australia as well as Singapore. But again, this is only theory, but this plays a role. 38% reductions happening in the vector control. So we need to control the vector control. Till these strategies are working, simplest strategy, empty wherever open pot or open collections of the water is there, please try to empty, put frequencies and empty the pot. That's what most important thing, and public health is recommending. Empty these things around your places. Don't try to stagnate water around your living places. So in summary, dengue is an acute onset of fever. Anybody has got sharp onset of fever, diffuse body pain, rash, diffuse conjunctival congestions, think of dengue. And if you think dengue, do CBC and LFT, elevated hemoglobin, low WBC count, low platelet, elevated SGOT, mild elevations in SGPT, think of dengue. Depending upon the timeline, 0 to 3 days, either NS1, 0 to 5 days, do dengue PCR, 5 days onwards to dengue AGM. Ideally, zero conversion is good, and try to replace orally as much as possible. If admitted, keep 5-3-2 in line and manage the thing. I'm happy to take a couple of questions, and thanks for the wonderful opportunity. Those who want to learn more infectious diseases, this is one of the exclusive 100-degree WhatsApp group. A lot of knowledge sharing is happening through this WhatsApp. Please feel free to use this one and join the group and learn it there. I open to the discussion. I'll just start sharing my presentations once.
Yeah, thank you, Dr. Kumar, for that quick overview of dengue. I know it's a very big subject and it's very difficult to summarize it beautifully in such a short span of time. So can I briefly invite the other two panelists, Dr. Ankit and Dr. Deepak, for giving their introductory brief comments if they want to really say something about their experience in managing dengue. Dr. Ankit, please.
Yeah, sure. Thank you, first of all, for this opportunity. Everything was kind of summarized. I know that's a lot of information. Few things that I wanted to add on or emphasize again is like, in addition to the presence of warning signs in when stratifying patients with dengue, the other thing is presence of comorbidities and special situations like say pregnancy or immunocompromised patients. They need to be closely followed up even if warning signs are not present at the moment. So that is one thing that we should be like more vigilant about. The other thing is the type of rashes in dengue. How I see is like three types of rashes. One is the one that has been described, the maculopapular rash, which is blanching erythematous. The second one is, of course, the petechial rash, which is, of course, a sign of complication from bleeding, etc. And the third one is the rash of recovery. So a lot of times patients will complain that they have this increase in the rash, which is extensively pruritic. And at that time, you actually need to reassure the patient that this is a sign of recovery. And in fact, if you will observe closely, you can see island of normal skin in the sea of red. That is how it is described. So that's the convalescent rash in dengue. That is one thing. And the other important point that I'd like to highlight, this is something that I've burnt my fingers with, is neglecting or overlooking other differential diagnosis, especially if it's in the peak dengue season. So always look at peripheral smears, always look at coagulation profile, especially if the history of fever is not very, strong. Don't miss out on things like hematological malignancies, etc., which can come with thrombocytopenia, coagulopathy, bleeding disorders, etc. And with respect to fluid management, that I would want to highlight specifically is don't do an overzealous fluid resuscitation. That was already emphasized in the presentation. That the critical period lasts only for 24 to 48 hours. And if we continue giving the fluids beyond 48 hours or beyond the critical period, there's a good chance that the patient will land up in fluid overload during the recovery phase. So you have to be very judicious. uh, the the uh, the main agenda or the main treatment approach remains fluid, but we have to be very careful when we are giving fluids. We don't have to give a lot of fluids, and more or less those things that I could think of. Other than that, any leading questions if we have?
Yeah, thank you, Dr. Ankit. I think one of the important points, particularly in the outpatient settings, I guess, is urine output monitoring, oral hydration and urine output monitoring, because the trigger for admission can be fall in your urine output. So that's a very easy marker for an escalating care. The second aspect, I agree with you about multiple infections circulating. And in Pune, for instance, now we have Zika circulating along with the dengue and chikungunya. So it becomes very difficult to really chase them out clinically. And because they are cross reactive flaviviruses, you can have problems with testing. We don't have PRNT available here in our facility. But what we have, and maybe you in your setups in Karnataka, in maybe Bijapur is look at tropical PCRs. There are multiplex topical PCRs which are available, which screen for 5 infections, and we do it very routinely, very earlier on after onset of symptoms, because that is a window of opportunity where you can detect it. Dr. Deepak, do you want to add something? There are a lot of questions. We can take these questions otherwise.
Yeah, thank you, sir. First of all, thank you for the opportunity. The lecture was almost exhaustive and it covered most of them. I would like to concentrate some of the things which I cover usually. I specialize in intensive care post general medicine. So some of the special populations I would like to just contribute. One of them is a elderly people. They have very low reserve. In fact, most of the people, elderly, frail people, we try to keep more in the intensive care, especially because of shortage of nursing as well. And we try to keep less reserve in escalating the treatment. At the same time, they behave poorly to even a slight amount of more fluid. They easily tend to go into the fluid overload. We really need to be careful with them. Second one was the hypertensives, where the most of the guidelines, the map of 65 or all those things, the blank targets are for non-hypertensive patients. For a hypertensive patient, I think even their map is adapted to the 75 or 85. Even there's a drop of map from their regular levels, we need to have a less reserve in escalating the treatment. And one of the most important thing and much neglected thing is bedside capillary refill time. So I don't really see the registers nowadays practicing the capillary refill time. It needs to be seen regularly. And for the fluid responsiveness, the criteria which was given classically is the hematocrit. But for in an intensive care, we depend more on a much more easier to access, like ultrasound, seeing the inferior vena cava, doing a lung ultrasound almost at every hour interval will give us a more detailed and much more earlier view of lungs getting congested. And patients who are on antiplatelets or anticoagulants are special thing for us. We commonly encounter because people who are much sicker come to us. Very tricky situation. Especially we handled, I think, in fact, in this epidemic, we had an ECMO patient. The patients who are dengue, they had a viral myocarditis, and we had to take them on an ECMO. ECMO itself needs a lot of anticoagulation, and the platelets are already low in the patients who are in dengue. So very tricky situation. So we need to, on one side, you need to transfuse the platelets to, because you need to keep larger ECMO cannulas. At the same time, you need to maintain the heparin and maintain the ACT as well. Fortunately, we could get down, but every day it's such a tension for the clinician who is handling the ECMO. And we have seen people going into the liver failure with post-dengue hepatitis as well. And one of the questions one of the delegates has asked was the role of cytokine filters in dengue. We had some experience on it. To be frank, I think we really don't know. So, but cytokine filters, especially cytosarb, we had some experience. If needs to start it, we need to start early, and we need to clearly have a clear markers when to stop it. And each cartridge usually we'll use for 24 hours, and we need to repeat the cartridge at first day, third day, and fifth day. At least 3 cytosarb filters we need to use till we get to know whether the benefit of cytokine filter is there or not. And last is the prediction of the severities, the clinically significant bleeding. We use, and in fact, we are actually about to submit for the protocol for ethics committee the APTT values. So we've seen that most of the dengue patients, the patients who are about to go into a clinically significant bleeding later part, has a degeneration of APTT. In fact, Ramraj Gopalan sir from Chennai has published one study on that. So where we saw that APTT is much more correlating rather than the platelet count in predicting the clinically significant bleeding. So these are some of the things I thought I'll keep. And last, I think one of the people has asked about this role of CVP. CVP, it's a tricky thing. There are very few studies, but you should not brush it off. CVP, you need to know how to interpret. The patient should be in the same position. Patient should, there is a role of 3. I'm like, you should not brush it, but if, the more important things are lung ultrasound and inferior vena cava, which are more useful. But if you don't have anything, CVP still can be used. Thank you, sir.
Yeah, thank you. So let me continue with some of the questions maybe directed to you. One is the role of albumin, and when you want to give albumin. The second is, do you think there is a role for N-acetylcysteine if there is an ALF in dengue? Then there some experience with HLH in dengue? Have you seen that? Cytosol filters, you have already said. Yeah, and fluid, I think tied to hematocrit, I'm monitoring based on hematocrit, the response as well as the need of the amount of fluid. I think that is what guidelines say. And guidelines say to repeat hematocrit every 5 to 6 hours. And, that's that kind of intensive. But what is your take on it?
Yes, sir. To start from the last question, hematocrit for us, the problem is the patients are too sick and they deteriorate too fastly. The turnaround time for the nurse to take the sample, get to the lab and come back, it's too, too difficult for us to get it. So we depend for a HDU kind of setup where the patients are semi-stable, hematocrit may be okay for us. But if they're too sick on ventilator, on multiple inotropes, we depend more on a number-based, the dynamic indices like on ventilators and the fluid responsive rather than the hematocrit. Having said that, still useful, sir. Second one was the albumin role. Albumin, we don't really use it in the initial period. We'll only use when the patient is going into the fluid overload. When there's too much of fluid in the lungs, we cannot give it. Then maybe we give it sparsely, but not much of an evidence-based for us. N-acetylcysteine, definitely, sir. When you have a liver failure secondary to dengue, or maybe we have seen one patient who has kept on abusing the paracetamol with a background of some CLD, then they landed up, they recovered from the dengue, but the liver failure has worsened. Definitely, there's a role of N-acetylcysteine, sir. And we follow the same protocol as other protocols in the other ideology. Last question was the HLH. We saw only one patient in the last 1 year. We basically suspected when there was the patient was not improving, the fever was continuing beyond 10 days. And there was initially the counts, they didn't improve. Basically, there was a lack of improvement of the counts and there was a organomegaly. And one of us, we sent the ferritin and fibrinogen, if I remember correct, and they were abnormally elevated. They were in thousands and thousands. Then we suspected and we got the diagnosis of HLH. Fortunately, he responded to the steroids, that guy.
Yeah, so that is the only indication for steroids in dengue, is HLH. So can I go to Dr. Suresh? Dr. Suresh, somebody is interested in knowing what is the difference between primary and secondary dengue.
Yeah. Primary dengue is a person getting first time dengue in his life. There is no previous history of a dengue. Secondary dengue means a person is getting second time dengue or even third time also. We have seen a couple of cases of third time dengue, proven dengue, we are talking about it. So primary dengue is first time getting dengue. Most of the time primary dengue is an acute viral fever. Most of the time complications won't happen. Secondary dengue, the chances of complication is more, not always. Don't expect secondary dengue means you always land in coagulopathy or going to land in shock or something. The chances of complications in second time, if you are getting dengue, the chances are a bit more. So that's called secondary dengue. And whatever happening is only secondary. We can't put tertiary, quaternary so far. But technically, yes, 4 times you can get dengue in your life.
Yeah, thank you for that. And maybe somebody asked about the difference between PCR and NS1. I know you told it, but can you elaborate?
I was questioning that because of lack of time. Yes, PCR is always whenever you got viremia, the best test is to find out viremia is present or not is a PCR, polymerase chain reactions. That can pick it up. Number of copies is bit low, as well as the sensitivity and specificity is much higher. NS1 depends upon what method you are doing and what lab you are doing it. A lot of rapid tests available for NS1 is also nowadays, but rapid test has got a lot of limitations, understand it. So the NS1 forms on day 1, day 2 and start disappearing very rapidly. But even though the viral load is coming down rapidly, I know the first few days of fever, the viral load start declining, but still the PCR, the threshold to pick up the low viral load is bit high. That is why if you want to make a diagnosis on day 4 to day 5, instead of NS1, I prefer dengue PCR because the pickup rate is much higher compared to NS1. If you want to do on NS1, do on day 1 of the fever. But unfortunately, most of the patients, first 2 days, they go to the local pharmacy, take some paracetamol, they land with you on day 3 and day 4. That point of time, when you think dengue and do the test, nothing is positive, you are got confused. NS1 disappeared, IgM not formed, you are confused. That point of time, if you want to make a diagnosis, use dengue PCR.
Thank you. I think another point here is the value of PCR in secondary dengue as compared to say primary. You have more viremia in secondary dengue, and it is for a shorter period of time. So you have a very short window available. And as you correctly mentioned, the sensitivity of NS1 also goes down because perhaps of previously existing antigen antibody complexes interfering with the NS1 result. So it can be quite challenging. I think the important thing is to pick up at the right time, which test you use the right time, as you correctly mentioned. Can I ask Dr. Ankit about IgM, the difference between IgM by card versus ELISA?
Right. So generally, first of all, there's a lot of issues with IgM tests, like the one mentioned in the case also where the leptospira IgM was positive. And then I see another case where typhi.IgM is positive, for example, in classical dengue cases. So first of all is that IgM has a lot of limitations overall because there could be a lot of cross reactivities and false positivities. So the pre-test probability, what disease you're suspecting, order a test specific for the disease. Don't order the whole panel unless you're suspecting the disease. And the second thing is between card and ELISA-based tests. The ELISA-based tests are more sensitive and specific compared to the card tests. That same goes true for the NS1 card test as well. So the approved tests or the preferred tests are usually the ELISA-based ones. As a rule, a positive NS1 on card can be taken at face value, but a negative one should not be taken at face value, should be confirmed on ELISAs. And for IgM, again, ELISAs are the more accurate tests, more sensitive and more specific.
Yeah, thank you. And would you also try to, this is a question on dengue co-infection with H1N1. So how
Right.
to go about it?
I mean, it wouldn't be too unique a situation or too difficult a situation to manage unless both the things get complicated. Say H1N1 causing ARDS and dengue again developing into a severe dengue. Because the management of dengue as well as H1N1 remains mostly supportive, you have to look at indications whether the patient qualifies for antivirals for H1N1. If the patient qualifies for H1N1 antivirals within 48 hours of onset, you can start oseltamivir, and then rest of the management is pretty standard, I guess.
Okay, and there's a little, if I can understand that question, is about the febrile. We have these three phases: febrile, critical, and recovery. So, is the febrile period in secondary dengue safe? And once the febrile period is over, do complications occur in primary dengue?
Yes, in dengue, primary dengue, after the febrile phase only, the critical phase enters. So the chances of complications in critical phase is always common. During febrile phase, suffering will be more, but complications is critical phase. So once fever period subsides. But regarding the first part, I'm also not able to clearly understand what he's trying to say.
I don't
But
know.
the febrile period, they're asking too short in the secondary dengue. That's what he's asking indirectly. But I don't think so. Any studies is complicated. But usually complications are more when patients getting second time dengue.
Yeah, I think I need to also emphasize here that the critical phase after defervescence or febrile phase can also be catastrophic. As you mentioned, that the febrile phase can be catastrophic. There's sudden onset development of fever. There can be a sudden onset development of the critical phase, capillary leak, and patients can just go into shock. So it's very important to closely monitor high-risk patients, patients with monitoring warning signs. Those, as you mentioned, there are limitations for the warning signs as well. Dr. Deepak, can I come back to you to ask about two things? One is bradycardias very common in dengue? And is it a poor prognostic marker? And what is the role of romilastin?
Romilastin, I'm not sure, sir. First one I could tell. Bradycardia definitely in an ICU patient, because they're already sick, we find it. Especially this is acidosis, is lactate, all of them contribute to it. Along with it, there will be definitely myocardial involvement. In fact, the patient I told you, the patient with a dengue myocarditis, he was being treated in the ward with the heart rates of 140, 130 something odd. Then he slowly landed up in a bradycardia, and then myocarditis, we had to take him on an emergency ECMO. So bradycardia is not that uncommon, sir. Unlike the classical teaching, we find it actually. And it's definitely, in my opinion, it's an harbinger of a sick dengue patient.
Okay, so to take that further, there's a question on, is there any role of steroids in dengue myocarditis?
No, sir, no. Most of the time, we had only experience of around, I think, 5 or 6 dengue myocarditis. Most of the time, it is self-limiting. It reverses within the next 48 to 72 hours. Our whole point is not to get afraid of this bleeding complications. We should be aggressive like any other patient. Proper supportive care, proper stabilization, maybe keeping an IBP, taking them on an ECMO, all of them we usually salvage, and we can actually get out of the ECMO much easier within 3 days. They have a good rate. It complicates when the lungs becomes white. We don't really know whether it's because of pulmonary edema or ARDS. That is the one, or because of the sick condition, we cannot take them to the CT. So it becomes more complicated.
Okay, somebody has asked, is secondary dengue can complication occur in first day? Well, I can answer that. It's it's a no. So normally you see this febrile, critical, and recovery phases. And second, the issue here is secondary dengue is basically infection with another serotype in an individual who has had a past asymptomatic or symptomatic clinical dengue with another serotype. And because of what is called as antibody dependent enhancement, that's the pathophysiology proposed for complications in secondary dengue, is what leads to complications. So you would usually go through the febrile phase and then you go to the critical phase. Not everybody goes to the critical phase in secondary dengue also. You should remember, I think it's only about 3% people who go into the critical phase, and there are various viral factors, host risk factors associated with the risk of developing critical dengue. So I think that's about all the questions from the chat bot. Okay, there's another thing about anybody has any idea about how does dengue behave in immunocompromised hosts?
Right. So I tried to review this topic some time back. So first of all, the phase of viremia can be prolonged in these patients, especially say hematological malignancies or transplant recipients, where the immune system is low, not able to clear off the viremia very quickly. So in these patients, the typical timeline of febrile phase, critical phase, etc., may not hold true. So the phase of viremia may be prolonged. There could be more viral pathogenic effects. So dengue manifestations has two parts. One is direct virus mediated, effects, and the other one is, of course, the major one, which is immune mediated. Now, in immunocompromised patients, we can actually have more viral specific complications also, in addition to the immune mediated complications. The only problem is the timeline, the classical timeline that we read about, it's completely off. And the overall the risk of poor outcomes is generally higher in immunocompromised patients. But management wise, nothing changes because we really don't have anything. As a general rule, whenever we are managing, say, I would say for transplant patients, for example, as a general rule for any active infection, we usually go down on the immunosuppression. Generally, we take down the MMF doses, maintain TAC and steroids at a lower dose. But for other immunocompromising conditions where you cannot really change the immunosuppression, there's not much to do.
Okay, so since you mentioned pregnancy as an important risk factor, can you elaborate more on dengue and pregnancy?
Right. I mean, dengue in pregnancy could be really, really challenging because, especially if it's in the third trimester, preterm labors, preeclampsia, etc., it's more common in patients with dengue. And the problem is more if the patient goes into labor. Now, the risk of bleeding, postpartum hemorrhage, everything increases. If you're forced to go for a cesarean section again, there are going to be issues regarding blood loss, etc. So you have to be well prepared, prepare enough blood products for transfusion, enough, supportive care team has to be mobilized and all. And still the outcomes can be poor, especially if it gets complicated by a severe PPH. because then, controlling the bleeding becomes a major problem, because you cannot control it by just removing the placenta or using, say, oxytocin, etc., which generally helps in other forms of PPH. In dengue, those things can be problematic in pregnancy. But as itself, dengue itself is not an indication for termination of pregnancy, and all elective procedures should be avoided. Avoid forceps and avoid induction of labor or tocolytic agents in general.
Okay,
One more
thank you.
regarding
Right.
pregnancy, most of the time people confuses with HELLP syndrome with the dengue platelet low. And in fact, like a couple of cases, I remember once a newborn start developing, vertical transmission is quite common. So the newborn start developing low platelets on day 3, day 4. That point of time only they recognize, because they thought of HELLP syndrome and profuse bleeding from the surgical side. And second thing, they want to keep little higher platelet compared to the less than 10,000 transfusions, because most of the patients going for LSCS, none of the anesthetists want to give spinal at a count of 10,000. They want to keep of minimum 25,000 is the recommendations, but most of the anesthetists insist 50,000 platelet to give spinal anesthesia. So they keep little high platelet transfusions, high platelet count. And second thing, the complications in the newborn also be monitored. Once perinatal transfusions happen, monitor the child also. That's most important.
Okay, there's continued interest in HLH and dengue. So how do you suspect, Dr. Deepak? If I think if you have a patient who is recovering, maybe, or if the fever is prolonged, or if there is a recurring fever and there is new onset pancytopenia with elevated triglycerides and elevated ferritin, then that is where you can suspect an HLH. Dr. Deepak, do you want to add something on this?
Yes, sir. That's it, sir. As you rightly said, I think you should quantify the HLH criteria at least 5 out of the 8. And as you rightly said, I think if the fever beyond the 7th day or 10th day is very unlikely in the dengue, you need to suspect either it's a co-infection, which will be usually obvious on the clinical examination. And if there's no clinical obvious signs, then you need to look for the cytopenias, you need to look for the high ferritins and fibrinogen, and maybe organomegaly, I'm not really sure. But if it occurs, it fits into your diagnosis.
Usually, hepatitis and liver cell failure is also one of the manifestations of HLH. So both occur together. Think about HLH as a possibility.
Okay, so is there a role of exchange transfusion or plasmapheresis in dengue complication?
So, can I take this, sir?
Yeah, please.
So I'm like, only thing is we haven't done it, but I have spoken to our colleagues in the pediatric setup doing this. They are like as a part of the therapeutic plasma exchange along with the CRRT. That is one thing in one of our hospitals of pediatrically. Second, especially when there's a liver failure as well. Second one was when you have an autoimmune encephalitis or post dengue, they develop a GBS. There may be some role, sir.
Okay, so do you have any experience on the neurological manifestations in dengue?
We have seen dengue encephalitis, one patient.
Anybody else? Ankit?
We have also seen dengue encephalitis. I can't recall any GBS-like presentation or other presentations as of now. But yes, encephalitis we have seen. We diagnosed it based on CSF analysis, where the CSF IgM was positive. PCR was not available at that point. So the CSF IgM dengue was positive in that patient with a compatible clinical history and MRI findings.
Yeah, one of the things which we have seen is optic neuropathy. I have seen optic neuropathy in 2 young females actually, post dengue actually, just after recovery of dengue, they developed an optic neuropathy. So it's a
Encephalopathy is more common, and ADAM is also can happen. And as he rightly pointed, Guillain-Barré can happen with any viral infections, and dengue is not an exception. So encephalitis is a direct invasion that is less likely, but encephalopathy, because of the underlying liver cell elevations or the underlying hepatic manifestations, sometimes encephalopathy is common. Encephalitis is reported, as you rightly pointed out, not only optic or other cranial neuropathies also, mononeuropathies also happen. And Adam, post-infectious like a demyelinating neuropathy is quite common.
Okay, let me take last question. I think we have 8 o'clock already. So maybe Suresh, doctor, you can take this. since platelets are not recommended really, and it has been, as you rightly mentioned, abused a lot in practice. So how helpful is immature platelet fraction? So I think
See,
it's just a corollary, right?
immature platelet is one of the prognostic indicator most of the studies are using whether the platelets start recovering or not. It basically says whether the platelet destruction site, whether it's a bone marrow versus peripheral destructions. If immature platelets are happening, this is peripheral destructions compared to the bone marrow to me. And one of the prognostic indicator we can think about it. Otherwise, like some people want to prognosticate whether the patient is recovering from dengue or not. Once they start seeing a lot of immature platelet, the person start recovering from the clinical illness. Some people use for guidelines, but as far as immature platelet in dengue is concerned, the data shows it's one of the prognostic indicator. When you start seeing immature platelets, the recovery phase patients start entering it.
Okay, thank you. Last two questions I'll take and then we'll close. One is the role of CRP and ESR in predicting complications. If I can answer, I don't think I have seen any studies really looking at using these inflammatory markers. And the second is maybe Suresh, you can contribute to this, is in the first 5 days, a person coming with fever and symptoms are quite confusing. It's undifferentiated fever. So when do you suspect bacterial co-infection along with viral or bacterial infection over viral so that you can prescribe antibiotics?
As I told earlier, if you're able to do the approach to acute undifferentiated fever is first thing whether the patient is stable or not. And then how to assess, use the Q-SOFA score. And the person is septic or the person is not stable, your threshold to start antibiotic or threshold to investigate more is highly likely. Second thing, try to localize. For example, if you're able to get urinary symptoms or whether the person has got pneumonia-like symptoms, yes, we can justify. So try to get localizations possible or not, whether it's UTI versus pneumonia. There is no localization is possible. The person is clinically stable. Most of the time, it is viral fever with systemic manifestations. Provided the patient is stable, don't do any investigations, don't start antibiotic. But once the illness lasting more than 5 days, or some history, for example, the history of typhoid means young people eating outside most of the time, and you're doing CBC on day 3, it showed eosinophenia, then yes, send cultures and start antibiotic. So it depends upon the clinical suspicions, one, depending upon the localizations and depending upon the sickness only, first 3 to 5 days going to play a role.
Okay, so yeah, I think Dr. Sangram, we can close this.
Yeah,
Maybe
there are one or two questions still left over. Just management of fluid replacement in hypertension dengue. They want hypertension.
Yeah. Okay. Dr.
There
Deepak,
is no major differences, even though we want to infuse the crystalloids. So crystalloids, I don't think so in hypertensive crisis. If you avoid NS, you can use the ringer like that, nothing wrong in it. So I don't think so. There's no major differences between hypertension and normal persons.
Sir, if I may just add one point to this.
Yes, sir.
Usually, as we initially thought, hypertensive patients, the cutoff should be a bit more when you're treating the shock. You need to maintain a MAP of 74, 85 because the renal perfusion pressure needs to be maintained at that level to at least get the urine output. That is one common thing because the registers in the initial period, blankly the survival sepsis guidelines tell you the 65 MAP. So they keep on doing that. But for hypertension, you should keep it. And most of the hypertensive patients have a heart failure with diastolic, the relaxation of the heart will be poor. So try to be in small aliquots of fluid when you're trying to replace instead of suddenly dumping like any other patient because they immediately go into the fluid overload. So only 2 points I thought.
Yeah, Dr. Suresh, can you type your WhatsApp number? They wanted your.
So you're having the thing that so you just circulate in a group, sir. So
I'll forward. Dr. Sanjay.
Yeah, I think we can conclude this. It was an excellent.
So before concluding, we'll have a just key takeaway, take-home message from each faculty. Dr. Deepak, from your side, what is your take-home message?
Sir, first of all, thank you everyone. It's a pleasure to listen to all of you. Only point is try to avoid patient getting shifted to our ICUs. Try to predict before and try to treat it before. And dengue patients getting in the ICUs is a specialized population. Most of the rules like other ICU patients apply to them, sir. You should not have a fear that they bleed. most of them, they actually in our practice, they don't bleed even at the less platelet counts. Like any other patients, they're keeping the lines, maybe keeping an ECMO, dialysate, whatever it may. Try to be not to be afraid and try to be aggressive in treating these patients, because if you tide over those 2 to 3 days, most of the patients will come out. That's it.
Yeah, Dr. Ankit, your
Yeah. So what I would just suggest is have a good index of suspicion. Educate your patients once you're diagnosing them with dengue, because as explained, majority of the patients won't require hospitalization, but they need to know when to come back to the hospital or to the doctor for further care. During in-hospital management, two important points is don't rely too much on platelets and don't give too much fluids. And of course, final point would be that please don't give antibiotics to proven dengue patients unless you are suspecting or confirming a secondary infection in your patients, which can happen in critically ill patients with prolonged hospital stay. But as a rule, please don't give ceftriaxone. I mean, it's really not necessary to give ceftriaxone to all patients.
yeah, thank you. Dr. Suresh Kumar, sir.
Sir, same thing what Hanky just told. Treat the patient, not the platelet. So we need to treat the patients and not the platelet. And dengue fever is not an indication for antibiotic. And he said about educations of the patients, I need educations of the physicians more important, because they want to start antibiotic, they want to start platelet transfusions most of the time compared to the patient's attendant. So once we've taken care of the patients, educations of the physician is more important. That's why API is doing today. So treat the patients, not the platelet.
Dr. Sanjay, your final comments.
Yeah, I mean, it's an excellent thing. I would underline what all the three have said, but also perhaps take a different additional view of trying to contribute to public health as well, in terms of trying to communicate to all of our patients, their community partners, for primary prevention methods, mosquito repellents, mosquito nets. They will not only prevent dengue, they'll prevent a host of mosquito transmitted tropical infections. So I think as an organization, also you should try to look at involving in educating the community about prevention of mosquito borne diseases.
Yeah, thank you. So I request Dr. Vishwanath, Secretary, for your vote of thanks.
Yeah, good evening, sir. Thank you at the outset. It was a wonderful presentation. As usual, Dr. Suresh, sir, thank you very much. Crystal clear, clinically oriented presentation. Also, thank the panelists and moderators, Dr. Sanjay, Dr. Deepak, and Dr. Ankit, for their viewpoints on various comorbidities and dengue. Of course, we do know there is a lot to be discussed on this, and each one of the clinicians would love to have more discussions on different case scenarios. But I think overall we could summarize the key points. That was the main thing. I also thank Dr. Sangram Biradar, my chairman, Dr. Murli Mohan, and all the delegates. I think we had one of the highest number of delegates today, of course, which underlies the importance of knowing about dengue. Thank you very much. Thank you all. Thank you.
Yeah, thank you, thank you one and all. Thank you, Suresh. Thank you.
Thank you.
Thank you.